So, we are on episode 3 with Dr. Babak Maleki from Toronto Eyelid Surgery. It's the first time that we're connecting. I've been hearing so much about you. I'm a Canadian Board of Aesthetic Medicine graduate. I know that you were just at the Congress. You were presenting as well over the last weekend. I saw you on stage. A
Oh,
lot
nice.
of injectors there that I saw. So, welcome to the episode, Dr. Maleki.
Oh, thank you. Thanks for having me, Alex. Nice to meet
It's
you
It's
virtually.
always a pleasure to connect with other injectors all around Canada and especially Toronto. I know you guys do incredible work. One thing that a lot of my patients were asking was everything regarding the eyes, because
Yeah.
a lot of injectors are doing filler on the under eye. But to be very frank with you, it shouldn't be for everybody, in my opinion. To be honest, it's a very select amount of people that should have, fillers in the under eyes and everything like that. You are a professor at University of Toronto, from what I understand as well. So we want to pick your brain a little bit on what we can do to try and improve medical aesthetics for the under eye area, whether it's surgically or non-surgically as well.
Yeah.
So, Dr. Maleki, can you sort of introduce maybe a little bit your practice, where you work,
Sure.
and what type of work that you do?
Yeah. So I'm a oculoplastic surgeon. So I'm a board certified ophthalmologist with fellowship training in oculoplastic surgery, which means that I specialize in surgery and aesthetic procedures around the eye. So things that I do commonly are things like blepharoplasty, upper lid blepharoplasty, lower lid blepharoplasty, brow lifts, lasers around the eyes, and as well as injectables around the eyes. So, yeah, it's an area that I'm quite passionate about, and I get an opportunity to speak about it frequently. Yeah, there's been definitely. I think there's more and more becoming a better awareness about what are the potential risks and complications with dermal fillers around the eyes. And as you pointed out, I think you're right. I think that there's a very select number of people that are actually good candidates for under eye filler.
Absolutely.
Most people are not, and so the people that in my mind are good candidates for under eye filler are people who have a true hollow, so that have a tear trough hollowing or a lateral orbital hollowing, who have a true hollow, but at the same time don't have eye bags, don't have a lot of skin laxity, and don't have a history of swelling, edema, or allergies around the eyes. And so the hollowing is kind of the quote unquote easy part to evaluate. The other aspects are sometimes a little bit trickier, and people get caught in traps in terms of injecting patients who they think are a good candidate for fillers, but in actuality they're not. And then that can cause a whole host of problems, which I'm sure we can get into over the course of this episode.
Exactly. So one big concern, and we're going to jump right into the fillers, because that's the biggest concern in my practice as well, and for other injectors as well, right?
Yeah.
And it's great to learn about injecting tear trough filler, whether it's with cannula or with needle, but it's the high degree of malar edema that we get from this procedure. I was doing, just for the sake of this whole webinar, I literally did a little bit of research, and the number that I found, and correct me if I'm wrong, Dr. Maleki, but the number that I found in terms of malar edema is actually quite high when we do periorbital rejuvenation with hyaluronic acid filler. I found the number to be roughly around 15-20%. Was that something that makes sense for you in terms of malar edema?
That definitely makes sense for me. And that's not just, and it's not always necessarily injector specific too. Like it's a lot of times people get into this discussion of, is it technique? Was it product? For sure, technique and product have some influence in it, but it's just the nature of hyaluronic acid fillers and the nature of the tissues around the eyes is such that we know that from studies that hyaluronic acid fillers as a broad kind of category are hydrophilic, so they trap water. Some of them, of course, are more hydrophilic than others. So the ones that are more highly cross-linked are definitely more hydrophilic than others. But even the ones that are not very highly cross-linked, even those ones have some capacity to draw in water. So they are slightly hydrophilic. And so if you're injecting the under eye area and someone has very thin skin, which oftentimes they do, and you're doing multiple injections. So usually the problem is not with the first injection. Usually people look good after their first injection. They're quite happy. It's when they come for recurrent dermal filler injections in the under eye area. What ends up happening is that the initial filler gets broken down by the body, but not to zero. It gets broken down to a certain percentage, whether it's like 20% or 15%. And then you do your other injection on top, which gives you like a layered effect. And then that second layer also draws in water. So now you're drawing in water at multiple layers at different rates. And then it overwhelms your own natural lymphatic drainage capacity. So we all have these channels that drain the fluid in our faces. And they kind of come in this area. And they drain in front of the ear and then underneath the neck. And so this natural system that we have to drain fluid gets plugged, gets bogged down, and then a very high percentage of these patients end up having malar edema. The exact number, I don't think we really know, because I don't think anybody's studied it in a prospective way. We just know retrospectively. Of course, people like me, my practice is skewed because I see all of the complications from injections around the eye. So in my practice, I see malar edema maybe like 5 to 10 times per week, and or maybe even more than that. So we're constantly dissolving filler, constantly trying to get rid of the fluid. And it's like an ongoing process. It's not like a one-stop process. So, to your point, no, it's A, super common, and B, it has to do with the nature of the product and the nature of the tissues around the eyes that leads to such a high rate. Because you don't get this type of issue as often if you're doing like jawline filler or chin filler. You don't get those types of issues. But around the eyes, because the skin is very, very thin, and the tissues are very thin, we actually don't have a natural fat pad underneath the skin, underneath the eyes. So things show up very, very easily.
Yeah. I think that's probably the biggest difficulty that we get with the orbital area in general, especially the periorbital area, is due to the fact that it's so thin, it's just less forgiving when it comes to filler. You know, if you're using a filler that's a little bit more stiff, you're going to create bumps, that's for sure. You have to have a nice soft filler that it blends in, and my technique that I've always learned was put it under the muscle. Generally put it under the muscle. Generally, you're not going to get a tyndall effect, and you're supposed to get a little bit less swelling. However, you can be the best injector ever, and hands down, I've caused some malar edema myself, just letting you know.
And so have I, by the way. No, it's not. I don't think it's something that's necessarily injector specific. Exactly. So you can be under the muscle. You can use very thin product. You can use very small amounts, but the nature of it is, especially if you're doing repeat injections. So like I said, it happens often on the second injection or the third injection. You'll be like, oh, that first one, worked really, really well. I'm really happy. Can you do that again? And we're like, okay, let's do it again. You do the second time, and then they end up coming back like a month or two later. So, can you dissolve it now? Well, it's just the nature of it just overwhelms your natural lymphatic system. So there's been a huge shift, honestly, and I think it's good that we're doing these podcasts. It's good that we're talking about it at meetings, because there's been a huge shift in people's practices, and now they're kind of understanding this a bit more. And I think it's really great that we're educating, first of all, other injectors, other providers, but also the public is also getting a bit more educated about these things, because we're hearing about all these celebrities getting injections. They're coming in with malar edema, like you saw Jennifer Aniston recently, and I think there was like Kylie Jenner. It's like these are
everyone's talking about it. Everyone's talking
about it. So it's a very hot topic. I think it's important that we and that we draw the right attention to it, and it's not to like shame anybody. It's not to say anybody that it's not a issue with any particular person. It's just the nature of these types of injections around the eyes. They're very tricky, and they're highly prone to developing problems. So I've actually shifted my practice over the last year or two in terms of being very, very selective about injecting HA fillers in the under eye. Like I said, it's only people who are hollow, and I tell them, this is good we can do one session of this, but if you're going to come to me and say, let's do this on a yearly basis, I'm not going to inject you. I don't think it's going to be something I'm going to repeat on a yearly basis, because you're just asking for trouble. So I said, we can do it one time. But I think that's kind of like, once you've done it once, it gives you like a little window to see what things will look like if you do injection, say, do I like it? But if that's what like, then we're looking for more permanent or long-term solutions, which I'm hoping I can get into with you.
Yes. 100%.
What are some alternatives to dermal fillers around the eyes?
Exactly. Actually, let's get into it right away, because that was a topic that I really wanted to get into was, fillers are great, but when I see your page and your Instagram page and I'm looking at the befores and afters, I'm getting I'm seeing amazing results, but it's the combination of three things, I would say, and three tools that I don't have in my practice, which is a non-surgical practice. So you have that possibility to add that surgical component to it. You can even sometimes replace the fat when you can, that I can't do. I only hide the fat. That's literally all I do. And then the other things that you offer as well is you'll even do a CO2 laser on top of it, which most oculoplastics will do to maybe hide the scar, tighten the tissues as well. And then if there's still a little bit of hollowing, maybe a little bit of filler at the end. Is that sort of that's how I understood it, but I'll let you explain.
No, absolutely. Yeah. So the aging process in the under eye area, it kind of goes like this. First of all, in terms of the structures around the eye, like we said, we have skin, we have muscle, and then at the lid cheek junction, you have important tendons, and then below that, you have other soft tissues. So when we're aging, it happens in different tissue planes and different directions. So, for example, we're all born with a certain amount of fat in our eye socket. Some of us are born with more fat than others, which is why some of us are a little bit puffier. Some of us are a little bit more hollow. So if you have a large eye socket, you may be hollow. If you've got a small eye socket, you may be more puffy. But by and large, as we age, the fat in our eye socket tends to want to protrude forward. That's called fat prolapse. So that's the first thing that happens as we're aging. The second thing that happens as we're aging is that we have laxity of the skin and the orbicularis muscle, which is a circumferential muscle that goes like this. And as the skin becomes more loose, it starts to hammock downwards like this, and then it creates a separation between your eyelid and your cheek, which is what commonly refers to tear trough. Tear troughs are actually a very common anatomical structure. Babies have tear troughs. Adolescents, so it's not the presence of a tear trough is not a pathology. What happens as we age, however, is this tear trough extends to the lower lid cheek junction, and then kind of goes all the way around, becomes a lateral hollow, and then you get like a semicircle, and then this gets more common. That's because the mid face is descending. You're losing fat in your deep cheek fat, medial fat pad. Start to lose volume in that area. So then it starts to become an aging process because your eye bags are coming forward. You're developing hollowing, and you're developing laxity. So if you think about the pathology of what's happening, if you want to rejuvenate the under eye area, you kind of want to have a solution or a plan for all these different components. So for example, if you have fat pads that are protruding forward, we would do a blepharoplasty to reduce that fat pad and to bring down the hill. If you've got laxity of the skin or the orbicularis muscle, then we would do things to tighten those tissues. So we can do combinations of CO2 laser resurfacing, because that's a powerful tool for tightening the skin, or a skin pinch, which is a little incision below the lash line to remove some skin. Sometimes I'll do like an orbicularis suspension to lift the midface up a little bit. So different levels, so different degrees of tightening based on the clinical presentation. If it's a mild degree of laxity, I'll do CO2. If it's a moderate degree of laxity, I'll do CO2 and skin pinch. If it's a lot of laxity, I'll do CO2 skin pinch and then a mid-face lift to kind of tighten that tissue. And then the last component that you alluded to is that the volume loss. So if you have volume loss, then at that point you can decide either to use either dermal fillers or do something called fat transfer. So fat transfer is basically a technique where we're using fat from another part of your body. So it could be a distant site like your abdomen. So that's called a fat graft, or we can do a fat transposition. Essentially, we're taking fat from an area of prominent fat and we're putting it into the area that you have not enough fat. And then we're volumizing that area. The main advantages of fat transfer over dermal fillers is that fat by nature is not hydrophilic, means it doesn't trap water by nature. Secondly, if you're doing a fat transfer, when you do that fat transfer, well, because of the first effect, first of all, you don't get Tyndall effect. Second of all, you don't get malar edema. Third of all, when the fat takes in that part of your body, let's say you've got like a volume deficiency in your midface or your tear trough, then when the new blood vessels are getting into that area and that fat takes, then that fat is part of your body and it stays with you for a very long time. So the longevity from these types of procedures is quite long. It can be in the order of like
years.
10 years.
Years,
Talking about decades, 10 years,
okay,
to be 15 years. So you don't need to come back and see me every year for an injection or every 2 years for an injection, because these are things that are more long lasting. And of course, the aging process continues. And as you get older, you're going to lose a bit of volume and your face is going to drop. But at least for the next like 5, 10, 15 years, things will be relatively stable and won't require any intervention. So if you think about it in that way, it kind of makes a lot of sense to rejuvenate the under eyes with treatments that are going to be, safe, effective, and will have a bit of longevity to you.
Exactly. I think having those 3 tools, the surgical component, the laser component, and even the non-surgical component, are 3 tools that are, to be very honest with you, almost essential for the periorbital area. Like, absolutely. I feel limited in my clinic, to be very honest with you, not having my surgical component to it to be able to fix these things, right? And that's the biggest component.
That's when you have to be super selective. So that's when you put your hat on. So if you're going to be selective about this, about using fillers, you want to make sure that your patients satisfy these 4 criteria: A, hollowing; B, absence of eye bags; C, minimal skin laxity; and D, absence of like edema or swelling in the cheek. So if you have these 4 things, then by all means, I think it's a good idea to do dermal fillers. Certainly, that's when I use dermal fillers in the under eyes. But if you have any one of those 4 things that are absent, or if you have a positive finding in these things, then you really need to kind of consider alternatives. And if you don't have it in your practice to offer these things, that's when it's a good idea to either refer out, say, listen, I think that you'd be better served by seeing so and so to address these concerns, because I think you'll serve the patient.
One thing that we spoke about a little bit was that lymphatic drainage around the eye area.
Right. Yep.
It's a component, we're adding hyaluronic acid filler, and on top of it, in our patients in the non-surgical practice, we're also doing, crow's feet. We're treating the crow's feet as well. Yes. It's like a double whammy on top of it as well.
No, that's
already had patients
bring it up.
Yeah, like there's patients just doing crow's feet, the lower injection, and they already have malar edema.
Yeah.
When you do under eye filler, are you going to treat higher?
No, I'm glad that you brought it up, because that's also an underdiagnosed condition. Malar edema secondary to Botox by itself.
Yeah.
And it's a well documented phenomenon. I certainly have seen it a lot in my practice. It doesn't happen to everybody, but let's say you have already a sluggish lymphatic drainage system. You need the contraction of your orbicularis muscle to push the fluid out from this area to get to the lymph nodes, to get to drain to the rest of your body. When you're doing Botox, especially in the lower part of the crow's feet, so I think the safe areas would be like the orbicularis above the lateral orbital rim, like above the lateral commissure. So this is a safe area. That's a safe area. But as soon as you're crossing the horizontal midline and you're getting into the lower aspect of the orbicularis, especially if you do a certain number of units in this area, it blocks your ability to smile, and then that blocks the. So that could be problematic. So if you have patients that have a little bit of swelling in their cheeks or have a history of that, definitely want to avoid Botox in this area here. You want to keep the Botox higher up. To allow for the maybe like lateral brow lift, but you definitely want to avoid the crow's feet area, and and especially somebody who's had issues with dermal fillers as well.
Exactly. So I'm glad that you spoke a little bit about it, because some injectors don't even know about that. The malar edema even after the exactly, and it's I see it more often than you think. It's just that you don't look for it. If you're looking for it, you'll see it. I'm sure you see it in your practice way more because you're actually looking for it. You know what I mean?
Yeah, exactly.
So, let's say a patient comes in with malar edema. Let's just say, okay, they might have had filler injected. They might have had Botox injected as well. And I see a lot in your clinic. You're doing a lot of dissolving. Okay, and in my practice, I dissolve, and I probably see them 1 week or 2 weeks later, just sort of reassess and say, you know what? Let's see how bad the quote unquote loss of volume is. Maybe I need to add a little bit more there, or maybe at that point, patient is happy and we're all good there.
Yeah.
How much when it comes to quantity, because now we're talking, filler still. How much in terms of quantity are you generally injecting per side dermal filler? dermal
Okay,
filler?
yeah, that's a great question. No, I like that question a lot because people are not transparent and open about it. And I think it's important.
I'll
So
tell
when
you my number. I'll gladly tell you how much I'm injected. I don't even care because this is the results I get realistically on my page as well.
yeah, no, tell me how much are you injecting typically?
I'm injecting most of the time. Going to be I use Redensity 2. I'm going to say it right off the bat. I use Redensity 2. I use 0.8, 0.4 on one side generally, 0.4 on the other.
So if you have, I would say if someone requires 0.8, 0.4 per side, they would have, I would say, a moderate to advanced degree of hollowing because that's the amount that if you've got mild degrees of hollowing, it's not uncommon that I would inject 0.2 per side. So 0.2, 0.2. So mild is like 0.2, moderate 0.3, advanced is 0.4 to 0.5. Really rare that I have to inject 0.5. If that's the case, it's usually they've got mid-face volume loss, in which case I would support the mid-face first. So I'll usually use, in the same line, I would use like our RHA3 or RHA4 to inject the mid-face area to support that. Once you volumize the mid-face, then you inject very little amounts of the Redensity 2. It's a good product because it's very, very thin and it tends to attract less water than others. However, it can still attract water. But and I inject very little. So that's why it never made sense to me. I don't know if that people, when they're injecting around the eyes, that they would inject or they would charge people by volume. It made no sense to me because it's not like the lips where more volume is equivalent to a bigger result or a better result. More volume actually is equivalent to a worse result.
Exactly. It should be priced almost opposite, actually. It should be.
You don't want to incentivize. Yeah, you definitely don't want to incentivize injectors for injecting more because that's what's happening. So like, okay, I'm going to see how many syringes did you? I injected 1 syringe per side. Okay, well, you're definitely going to get into some trouble. Whereas if someone says I'm injecting like 0.2 per side or 0.3 per side, well, what happens to the other whatever X, Y, Z? I just say, listen, we'll use it. If we don't need to use it, we discard it. Like it's not something that we have to use. It's not like you have to use the entire syringe. Or if you have another area of your face that you want to use it, you can use it. But fillers are very particular because they're specific, right? So if I'm using Redensity 2, I'm not going to use it to volumize the chin. It'll do nothing, or the jaw. It'll do nothing. So you have to use the right product for the right area. And I think that if you don't have a place to put it, do not put it in. Like, don't feel obliged to use the whole product. So listen, that's why it makes more sense to when you're charging, your clients, charge them by areas. Listen, I want to give you a good result. I'm charging, this is the area. I don't care if I have to use 0.1, 0.2, 0.3, 0.5, whatever it is. Sometimes, we use more, but it's the area that you're treating. We're not treating a volume. Lips is the only area that I think it kind of makes sense to do volume, but even then I would say you can do area too, but you can say, okay, I want to have bigger lips. That's fine. We'll inject like 1 ml as opposed to half ml.
I think in Canada, because there's so many clinics that are still selling it, still selling it per syringe or per volume, that patients are seeing it more as a commodity. And when you see it as a commodity, you're saying, well, if I'm paying for the full thing, I want the whole thing. You know what I mean?
Right.
It's more.
So then the provider feels pressured to use it. You're like, oh, I got to use more volume. It usually equates to worse outcome and more problems. So,
like you say, more money to more problems. I say more filler, more problems. You know what I mean?
More problems. Yeah, exactly. So I hope that kind of things change and people start, once they start hearing the message. But I think that for the more experienced injectors who've gone through this and they've been practiced for long enough and they've seen complications, they understand this. So the more experienced injectors that I talk to, they all charge per area for the under eyes, just because it just makes no sense to charge per volume, because you're going to inject like 0.1 or 0.2. You're like, okay, so what happens to the rest? Like so it doesn't make any sense. Yeah.
And I think that's the way to honestly do it. I love that answer, by the way. We can go into the whole conversation of how injectors are incentivized, and I can spend hours talking about it, but we're going to stick on the eyes with you today, Dr. Maleki. The other thing that I want to talk to you about was, I know we went over hyaluronic acid filler, but what are your thoughts on PRP in the under eyes area?
Yeah.
What are your thoughts on this new thing called exosomes that are coming into the market as well?
Yeah, I think there's a role for all these things. You just have to be very clear about what they're doing and how they're affecting the. So when I think about PRP or exosomes, I'm thinking about growth factors. I'm thinking about how it's improving your skin quality.
Yes.
So it's not about volume. So
yes.
if you're hollow, PRP is not going to help you. So if you got a hollow, a deficiency in volume, if someone is trying to tell you that I'll be able to correct your tear trough, they don't know what they're talking about, and I think that you're just going to be, doing something that's. But if you're trying to improve the skin quality, like if you have crepey skin or slightly pigmented skin, I think it could be useful. I like to use those in conjunction with some sort of energy-based treatments. So I'll do either microneedling with PRP, or I'll do CO2 with PRP, or something because what it enhances the results. What it does is it'll cause a micro injury to the skin. The skin has to repair itself, and then you're adding the exosomes or the PRP to help with the recovery process, and then that'll really enhance the results. So I think I like using it that way. So CO2 plus PRP, microneedling with PRP, Morpheus with PRP, anything that's going to be a controlled injury to create a healing response, and then adding that on top of that. And there's another thing that's come out recently last year, is something called NanoFat. Have you heard of NanoFat?
I have.
So
it's really being popular these days. I was actually going to ask you about NanoFat around the eye area, actually.
Yeah, so NanoFat is essentially the growth factor. So it's essentially, think about it like exosomes or PRP, but it's coming from your own body. So you're taking the fat, you're filtering the fat, taking away all the fat cells, and all you're left with is the growth factors. And it's about 10 times more potent than PRP is. So if you're doing like treatments for hyperpigmentation or the crepiness of the skin, it's really like a huge advantage to be able to use that as a tool. So I'll use that oftentimes in people who have got like crepey skin in their under eyes. So we'll do Microfat injections for the tear trough, mid-face area, and then NanoFat for the skin under the eyes in conjunction with like a CO2. Wow. I think it can give incredible results. And so
have you been using regularly NanoFat in your practice, Dr. Maleki?
Yeah, I just started in the last like 6 months. Yep. And
nice.
It's
great results so far.
So far, so good. I've been using that. Yeah, I've been really impressed with the results we've been getting with the NanoFat.
Do you think that, and there's going to be a shift, to be honest with you, I think injectors are fully aware about the difficulties when it comes to hyaluronic acid filler. When we were hearing in conferences about NanoFat, I was like, this is a great idea. There's no malar edema. There's no Tyndall. It can last a long time. Why are we not just using NanoFat for the under eye area? Do you think that that's for oculoplastic surgeons? Do you think that's going to be the future in your practice?
I think so. Yeah, it's even in the oculoplastics community, there's only a select group of people who are doing it. Yeah, I think it's relatively new, but the ones who we're getting good results. I have a good colleague of mine in California has been doing it for a while, Kami Parsa, and then a few other people.
Yeah, Dr. Parsa. Yeah, I follow him as well. Yeah, he's excellent.
Yeah, so I think it's like a lot of things. There needs to be there's a learning curve with it, and and once you adopt it, then you can get some pretty powerful results. But that's what the future is looking like. Yeah, for sure.
Amazing.
Less HA fillers around the eyes and more microfat, NanoFat.
Microfat. Yeah, exactly. But are the injection techniques, just out of curiosity, the NanoFat that you're placing, is it also underneath the muscle where you're placing it?
It's like intradermal. Because it's more liquid, it's more soft. So intradermal and subdermal. So those are the two liquids. Whereas the microfat is more like the traditional filler that we use. We place it submuscular, so microfat is for volumization of the mid-face tear trough area. And then when you get close to the skin under the eyes is only about 1 millimeter in thickness. So you can't really inject any fat per se in that area. So the NanoFat is the ultra refined of fat that we're using to kind of inject that skin area, which will help volumize and improve the skin quality, right? So you're getting, so it's like, think about like the equivalent of doing like Redensity 1, like a skin booster type of thing around the eye. So it's kind of boosts the skin quality, but it has more long-term
longevity. Has longevity. What do you think about skin boosters for the under eye area?
Yeah, I like it. I like it better than HA fillers. Because the skin boosters, because they're not cross-linked, they tend to volumize that area, give a bit of a boost to the skin, helps with wrinkles, and they tend to produce slightly less problems. Although you can, if you over inject, that you can also get into issues, but it tends to be less problematic than the cross-linked HA fillers.
It's hilarious because the more we talk about it, HA fillers just going down and lower down the list of our tools that we normally use for.
Yeah, especially around the eyes. Yeah. Like I said, I foresee that HA fillers are gonna probably remain a tool for other parts of the face. Like if you want to do like I said, chin. If you want to do lips, if you want to do jaw, maybe like deep
with HA.
I think those are safe areas. You can do it, and if you place it properly, you'll get good results with little complications with the right technique. But I do feel like the move and what's happening and the trends are happening in the next year and the next few years is going to be, you're going to see less and less people injecting HA in the tear trough area.
100%. Yeah, exactly. And I think that's a good thing, to be very honest.
I think it's a good thing. Yeah.
I think it's a great thing, to be honest, because I mean, especially with this whole celeb and Jennifer Aniston thing, and I hate bashing on celebs because it's not their fault at all. It's maybe more the responsibility of the injector. People see these and now they're aware about it.
Yeah.
Before we weren't even aware about these things, right? People were just injecting under eyes and we're just like, you know what? It's no problem, no anything. And then we see all these complications. You probably see way more complications than my practice as well. That's pretty much what you do. Now, besides malar edema or swelling at the under eye, I'm actually curious to see, what are the other types of complications that you see from other clinics that get injected somewhere else and then they come see you?
Yeah, I'd say malar edema is the number one thing. Malar edema and festoons are kind of interrelated issues. Festoons is when you have so what happens when you have malar edema is that you get swelling effects. But even if the swelling goes away, even if you treat the swelling either through hyaluronic injections or getting rid of the fluid, because of the stretching effect of the skin and soft tissues, you can get this thing called a festoon. A festoon is basically like a hammocking of the skin. So it's just like laxing the skin. And we can insert some pictures of people with festoons that I can show there. But basically what it is like a hammocking of the skin and soft tissues in the area that doesn't go away with just dissolving the filler and getting rid of the edema. So it's just think about like if you're overweight and you lost like 100 pounds, what happens to all your skin? It expands.
Fully stretched.
The only way to get rid of that is to do a tummy tuck to get rid of the skin. Losing weight doesn't necessarily affect that prop. So a lot of people with festoons require treatment. So I'll use like energy-based devices to treat festoons, but also surgery to get rid of the excess skin and soft tissues. So that's a common one. So malar edema, festoons. Those are probably the two most common
big
things.
Ones,
Luckily, the other
complications, maybe Blepharoplasty.
Yeah, blep complications are related to the. I would say a little bit more of the inexperience of the plastic surgeon who's dealing with this under eye area.
Exactly,
so the most dreaded complication of a lower lid blepharoplasty is lower lid retraction.
Yeah.
Lower lid retraction happens when you don't have enough skin. The skin is tight and the lid gets pulled down. So you're normally, if you look at somebody's eyes, you're not supposed to see the white of the eye below the iris. But if you're seeing a lot of the white of the eye, especially if it's unilateral, it could be that there's retraction there. And that happens oftentimes because as we age, like I mentioned at the beginning, we don't just age in one tissue plane. We're aging in multiple tissue planes. So like the tendons, the lateral canthal tendons are becoming loose. The orbicularis is becoming loose. The skin is becoming loose. So if you're just doing a skin pinch to remove skin, which oftentimes is done, by a general plastic surgeon, and you're not tightening the lateral canthal tendon, then you have a vector pulling the lid downwards with nothing maintaining the lid in its normal anatomical position. So that lid gets dragged downwards. So when I'm doing a skin pinch lower lid blepharoplasty, I'm always assessing the lateral canthal tendon and the orbicularis muscle. Say, is this muscle and this tendon loose or is it tight? If it's loose, then we tighten it and we make sure that the attachment is secure on the lateral orbital rim, which is the bony attachment there. So I think that's a common problem. Luckily, it's becoming less and less common. I think that plastic surgeons are becoming more aware of it, especially the ones who are not performing it as often. And if they've got a lot of laxity, if they don't know how to do the tendon tightening, because some of them don't, they'll refer those on. Same thing with upper blepharoplasty. When we're doing upper blepharoplasty, the traditional upper lid blepharoplasty is removing excess skin. But then sometimes it's not just a skin problem. Sometimes there's a skin problem and a muscle problem. The levator muscle can be dehisced. So we'll end up doing like a ptosis repair with a blepharoplasty. So it's just like there's little subtle things that are important to be aware of when you're dealing with the eye area. That unless you're doing it often, unless you're trained in the anatomy, and you've worked with enough, it's very easy to miss things. And then it's never by on purpose or by ill intention. It's just because, well, your training wasn't didn't prepare you, and B, you didn't recognize what the underlying kind of problems were.
Exactly.
So I think those are things that, luckily, as we're getting more educated and things are going out, people are becoming more aware of it. So I'm seeing less and less of those types of complications, but they still exist.
But these complications are questions that my patients ask me all the time, because a lot of them, I tell them, look, I can't deal with this skin. You're going to need a blep. And I refer out to get these procedures done, right?
Yeah.
And I always send them most of the time to my oculoplastics, because I feel like, plastics is good and everything, but plastics, sometimes they only face on face and they only focus on body, right? But oculoplastics, that's literally all you guys do. And not only that, I think your knowledge of anatomy is probably top notch when it comes to this area. I mean, I've learned a huge amount just by looking at your page and looking at the anatomy when you're showing those in surgery, like in operation, actually. So I understand these things, because on a textbook, learning this is not easy on a textbook. I'll give you that right away.
Yeah, for sure. Yeah, no, you're right. Well, I think it's neat that people are recognizing, because I'll tell you, like 10 years ago, I've been in practice for about 14, 15 years now. When I started my practice, there were very few people who even knew that oculoplastics was a specialty.
A specialty.
It was a very, very not a very well done. Even today, I would say that a lot of people are not aware of it. But I would say more and more physicians, nurses, and general public are becoming aware of it. So I think it makes sense. That there's different people who are, just like if you're going for a heart transplant, you're not going to see a general surgeon for a heart transplant. General surgeons are good for some things, and you're going to see a cardiothoracic surgeon who does heart transplants for your heart surgery. You're not going to, even if you're having like a brain procedure, neurosurgery, you have like subspecialty areas. Medicine's become super specialized, right? So if I have a brainstem tumor, I want somebody who deals with brainstem all the time. So It makes sense in cosmetics too. If you're doing like rhinoplasty, if I was that, I wouldn't want to see a person who specializes in rhinoplasty, because rhinoplasty is a very complicated procedure, and you want to make sure you're doing it. But so same thing with the eyes. So the idea that someone can become an expert in so many different areas of the body is like, it's hard to like even wrap your head around it, because I do blepharoplasty something like 15 times, 20 times per week, different types of blepharoplasty, different indications, techniques are always varied. And so I've done maybe close to 25,000 eyelid procedures over my career. So
insane. Wow.
It's really hard for somebody who's doing on a weekly basis tummy tucks, breast augmentation, facelift, nose jobs. Like, you're not going to be able to do as many, and then your baseline level of knowledge will, because of your training, won't be the same. So A, you're not trained the same way. B, you don't have the volume. So it's really hard to kind of get those detailed types 100%. Of procedures done. And so,
And there are certain procedures that we know, especially with blepharoplasties, that require that extra expertise and that precision and that finesse to give you the right result. Rhinoplasties, if you look at some of the data, the percentage of revision rhinoplasties is 50%.
Crazy. It's crazy.
Insane. It is absolutely insane. Now, how many people know that stat, and how many patients are aware that you're going to probably have to do another rhino right after that? Probably not that many, to be very honest with you. Now, one thing I'm interested in knowing, though, because we're talking about the eyes, how many times do you think we have to do a revision blepharoplasty? Now, of course, it depends on who's doing it, right? Depends on who's doing it. Yeah, I get that.
Yeah, depends who's doing it. I would say that revision blepharoplasty, thankfully, is not as common as revision rhinoplasty, as far as I can.
Yeah, thank God. Thank goodness.
But when the problem is that when someone requires a revision blepharoplasty, usually the indications or the results are a bit more catastrophic. For example, if you've got lower lid retraction, there's a huge functional problem with your eyes. If you can't close your eyes, there's a huge functional problem. When you have, so it's usually it's thankfully not super common. I would say maybe it's in the order of less than 2% of all blepharoplasties, so not very common. But if you do develop a problem, it's nice to know that the person who's doing your blepharoplasty knows how to treat do the revision.
Exactly.
The revisions are definitely more complicated than primaries and require a different skill set and different techniques. And so just to give you an example, if you got lower lid retraction, sometimes we'll have to use other tissues to kind of bolster up the lid. And there's a whole bunch of other issues that are important. Just like with revision rhino, like we do revision rhino, they'll have to borrow tissues to rebuild the bone or the cartilage. And so they're delicate procedures, but I think that it's important that, when you're researching and trying to figure out who's doing your blepharoplasty, that the person that does it also is comfortable and is able to do revision work too. And I do a fair number of revision work from colleagues from other specialties. Not that it can't happen to an oculoplastics, but it's less common, and at least you have the skill set to correct
these things. Yeah, and I tell all of my patients, you want to go to see a practitioner, whether it's surgical or non-surgical. You need to see a practitioner that's able to know and manage complications. You absolutely have to, because what's the point of getting a procedure done and you're re-seeing that same person later to get it refixed and they have never fixed it? That's horrible, whether it's surgical or non-surgical.
Exactly. Yeah.
Either or. Both are extremely important, but even more so surgically. Right?
Yeah, because usually the consequences are usually more severe. Usually, like there's
absolutely less reversible too. Less reversible
too, for sure.
Exactly. For sure. Thankfully, HA filler, you can reverse it. Thankfully, you know what I mean?
Yeah.
But the other thing I want to talk to you, because we have a couple of minutes left here, I don't want to take too much of your time, but the last thing that we kind of touched a little bit was hyperpigmentation around the eyes. This is a big challenge for me, and maybe for you as well, or not. How do you approach this problem, Dr. Maleki?
Yeah, that's a great question. Yeah, because a lot of people come to me and come to you too for saying, look, can you kind of fix my dark circles?
Yeah.
Well, your dark circles, there's 3 reasons why people develop dark circles. One is maybe they have a true hollowing. Like if you have a true hollow, and so light, when it hits the hollow, it doesn't reflect back to the person that's seeing you. So then that's one cause. 2, it could be a shadow effect from like an eye bag. So if you have an eye bag and it's a shadow, that's I
sorry to cut you off. Okay, some patients, and I noticed this, that have a huge frontal bone, and their eyes are kind of receded. They do have a darkening, but more from shadowing.
Yes.
That's true, right? Yeah, that's shadowing.
So if you have a very prominent brow bone, orbital bone, and you pocket, there's a shadowing effect. So that's the second reason. And then the third reason, which is probably the more difficult thing to treat, is the hyperpigmentation of the skin. Yeah. So people have different skin amount of melanin in their skin due to their ethnicity. We have the Fitzpatrick scale, like 1 to 5, that we can categorize people. So if you're on the higher range of the pigmentary scale, there are things we can do to help decrease the pigmentation a little bit, but you're not going to go from a Fitzpatrick 3 to a Fitzpatrick 1, right? No. So that's not going to happen. So what are the things we can do? Well, we can, first of all, work on using some skincare products. I think the number one thing is brightening creams plus sunscreen. Like if you have a tendency to produce pigmentation, you need to be using sunscreen all the time. Even standing by a window right now, I'm standing. Like I applied sunscreen like an hour or 2 ago because I know that through this window pane, there's UV light coming in. This window is not blocking UV light, so you're constantly being exposed to UV, even if you're indoors. So that's the one thing. You can use pigment control creams, which are 2 categories, like the hydroquinones, which is like usually prescription based, or you can use the non-hydroquinones creams that. So
we have that in the clinic as well. We have the hydroquinone and non-hydroquinone.
Yeah, most people have those 2 categories. And then finally there's lasers, and lasers are a good way to treat hyperpigmentation. In our practice, we're fortunate to have a lot of great lasers, from CO2 to erbium, Nd:YAG. They're all slightly different because they target the skin at different. They have different wavelengths, so they target the skin at different depths. But the idea is that you can actually lift off some of the pigmentation from the skin at different levels. So more superficially, more deep, depending on what you target. So there are ways of brightening the skin and improving the skin quality. And then if you add PRP or exosomes or NanoFat, that's even going to enhance that effect even more. So that's how I look at that in my practice. I'll say, listen, I'm evaluating you. What is your hollowing? What is the shadowing effect? what is your level of pigmentation, and then what can I offer you? And it's nice to have a kind of a full armamentarium of solutions to be able to treat this, because it's actually quite a challenging thing to treat. Like this dark circle thing is like it's not one thing. It's usually not one thing.
It's probably the most challenging thing in my practice, to be honest with you. I can create great facial contouring. That's easy to do. You know what I mean? Putting filler in somebody, that's easy at some point. But treating things topically in an area that has such thin skin and trying to brighten it up with all the things that we have, it's not easy, to be very honest.
That's true.
So I'm glad to hear that it's still a challenge for you.
It's definitely a challenge for me. It's a challenge for dermatologists too. I'm giving a talk in the fall, October. Have you heard of, do you follow David Lim? He's a dermatologist from
Australia, Brisbane. Amazing. Amazing stuff.
He's really, really brilliant. Really, like one of the smartest dermatologists that I've ever, had a chance to speak to. And
love this
so
guy.
we were chatting about this issue about this dark circle thing. He says we should do a talk on it. So we're going to give a talk in, I think, October at the Canadian Aesthetic Conference. They talk about surgical and non-surgical approaches to hyperpigmentation, because it's challenging even for experts who are in this field.
Exactly.
And
Exactly. He's one of those dermatologists that I really follow, only because he breaks down the science to you, like, and he gives it straight. He gives it to you.
He's on point. Now he knows his stuff. He knows all the different, the science behind the lasers, the science behind the cream. I'm excited to kind of to give that talk with him.
Amazing. So it is 4 p.m. It is Friday. Right. It won't take any more of your time. Thanks. One last thing, our listeners want to know, what's your next presentation? Are you offering any training in injectables? For those who are listening, there's some people probably in Toronto that might be listening as well. What are your next projects coming up for 2024, Dr. Maleki?
Yeah, so for this, I just gave a series of talks at CBAM last weekend. This summertime, I'm just going to take it easy. No talks over the summer. Just going to enjoy, do a bit of R&R. With the family. And the fall, we'll kind of kick it back into gear again. I'm giving a talk at CAMA. I think it's in October, and I'll probably be organizing a few training sessions. So stay tuned for 2024. I think the big thing that's going to happen in 2024, as we kind of alluded to, is this whole idea of like training with fat grafting, microfat grafting, NanoFats. So I'm going to probably be providing some training on that in the coming year. And then exosomes and PRP. I think that's going to be the big thing for 2024. Going into 2025, I think this is going to be like something you're going to hear a lot about at conferences. We've already started talking about it. I think that's the big thing to happen in this next year.
Amazing. Very exciting stuff. I keep following you, so I'll keep seeing you on your social media and everything like that, Dr. Maleki. Thank you so much for your time. It was an absolute pleasure and honor to have you on the podcast. But thank you so much for your time, and I wish you have an amazing weekend as well.